This is the view from the collaborative members. First, thank you for volunteering.
I think it was more voluntolding, but
For sure.
There may have been some arms twisted. Jackie is going to be the timekeeper for this one, so she'll let you know when you have a minute and when your time is up. We're going to hear from 6 of our collaborative participants. They each have 6 minutes to tell us about why they selected their project, describe their project, what was great about their project, and what they would do differently in the future. We're going to hold our questions again, and we'll have an open forum at the end of the panel where you'll get a chance to discuss what did we hear, what are our reactions, and what are our questions of understanding, and for whom. I'm going to let them introduce themselves. Since there are 6 of them, we're going to start the introduction here. You'll make your presentation, then introduce, then presentation, introduce, presentation. You get it. We're going to go from left to right with our presentations. So please give our panelists a warm welcome.
Me? Okay. All right. My name is Elias Curry. I am the Director of Quality at Havasu Regional Medical Center. And my partner on this was a few people, actually. Adam Collins, who was our manager for our inpatient units, and then Suzanne Del Vaccio, who's our CNO. I couldn't make it out today, so I get to be the rep. So why did we pick our project? And I'm using a cheat sheet just because it organizes my thoughts. So there was actually 2 big reasons that we decided to go with this project. Before the collaborative had went on, we had a situation come up that got brought to the quality side's attention during one of our safety champion meetings, and that's like a front of the line staff meeting, where we had a patient who was identifying as a male, but going to get surgery, get a hysterectomy done. And so obviously through that, there's a lot of questions that are gonna come up when pathology gets, their specimens down there, they're a little bit confused on what's going on. And so we realized really quickly that we didn't have a platform or a way to kind of handle those situations. And so that's a big reason towards that. The other one was from the risk and quality side, I was curious to see what our grievances were and what our complaints were around gender identity questions. And so there wasn't a ton, but there was a few, which means that there is some of our patient population that isn't having that same experience that other patients are getting. And so we thought it was a really good starting point for us to implement the form of collecting that information from our patients and then working on educating our staff on that. So really kind of just describing our project. Havasu's part of LifePoint, and so it's a bigger system. So anyone that's part of a bigger system typically knows that some of the things you want to do can take some time. You have to kind of work up the different levels. And so we were all on board on the hospital side, but implementing something like that into our EMR has to go through a few different chains and includes a lot of education. And so more of our work was on the kind of system work and putting that in place. And LifePoint doesn't have all the same EMR, so it was working with the facilities that have MedHost and making sure that we were all kind of getting that rolled out to us at the same time. So it was a great process. Everyone knew and had that same goal. But just kind of implementing that was the harder part. And then going through the standards, right? So making sure that we vet the questions out to ensure that they're appropriate, how we're going to utilize that, how we're going to educate our staff, because that's something new that they're going to be asking. And then they may get pushback from the community. And I know I was talking to some of the other people at my table, and they actually experienced a little bit more pushback, I think, from their communities than we did on why we're asking those types of questions. That was a pretty smooth transition for us, but getting that approved through the board and then implementing it, and what are we doing with that data? So being able to utilize it. So we're kind of to the stage now where we collect the data. We have a way of pulling the data easily to assess that, compare it to different health standards that we want to look at, and really kind of start our journey, I guess, on health equity and kind of meeting a lot of those new goals that are coming out with the Joint Commission on how you're measuring health equity, how are you bringing that up to your governing board, what are you looking at, what data are you analyzing, and then what are you using that for, what action plans are coming from that data that you're analyzing, making it put to use. So that was kind of our big project, I would say. what was great about your project? The collaboration is always a really good thing. I was happy to see that a few other areas were working with gender identity and some of the different SOGI data. And so that was really nice, and I'm excited to hear some of the feedback on their projects as well. Always kind of creating a culture where the staff feel that when they speak up about something, we're able to get it accomplished for them. And so it was nice that it was brought up to us from frontline staff as an issue. And then as a leadership team, we were able to kind of go back and say, hey, we were able to accomplish this for you and achieve this for you. And that resonates with them. It lets their voice know that they're heard. And so that's the type of culture that we want to create over at Havasu. And then what could you do better or differently in the future? So there's always a lag time. Patience is always a big thing, right? You have something that you want to achieve and desire, but you have to, anticipate that there's going to be some setbacks. So I didn't necessarily set up all of those when we were doing our project and building it out, some of the setbacks that could occur. So being a little bit more adaptable probably would be good. And then we are still facing a really big issue with the rollout of it. So we are doing great with getting the question there and collecting it. But one of the problems that we've realized afterwards is that it wasn't so easy to make it visible to the staff, like on that frontline EMR page when they're logging into the patient chart. And so that's kind of what I'm currently working on, is like a further issue. And so that's our goal for the future, though, is to continue working on that, making it visible so anyone that goes in that chart can actively see that identity. And that's it for me. 1 minute to go.
Good job.
You guys are welcome.
I'm Bethany Mattingly. I'm representing La Paz Regional Hospital out of Parker. So we're just like 45 miles down the road from Elias here. My role at the hospital is a little different than probably everybody in the room. I am the director of surgery. I'm not the quality person. I worked with the quality person, and I worked with two different chief nursing officers, and that's how the idea first came to us, was from Maria Martinez, our now retired CNO. And it was actually really perfect timing in the way that we got involved, because we were sort of at the point, we didn't have those patients necessarily like Elias had, but we didn't really know what we didn't know. We didn't know what we weren't collecting. We were barely collecting anything we figured out through this project. And so that's why we got started. Like, we were probably like the preemies of the project, because we didn't know what we didn't know, and we didn't know what we wanted to collect and what we needed to collect, how we were going to go about collecting it. So we've had some barriers to collecting everything, or trying to collect things. But what we identified was the fact that the software that we were using with the clinics was adaptable to be able to collect more data, but the software that we use within the hospital did not have any budge room whatsoever. But it was perfect, because we're on the verge of moving to a new EHR purchase, and so it gave us a lot of pre-work to do before we move into that purchase. So in that way, the timing was very much impeccable. So what were your other little notes there?
The other questions?
The questions. So those are the things that went really well. And we were able to decide as an organization what we wanted to ask, how we wanted to go about asking it, and we had board approval on all those things. So, and we're a small little, solely nonprofit facility in a little place. So it's not like we face the challenges of like huge structure to try to implement change or move forward with things. We were able to have some very key discussions with key stakeholders and then move the process forward. So that was super luxury for sure. And I honestly don't think that we would do one thing differently. Like the collaborative came about, the timing worked out fabulously as far as learning what we needed to collect and the reasons why we need to collect this. Of course, we're always in a place where we ask the question, okay, we're collecting the data, yay, then what's going to be the next meaningful implementation of this data so we can serve our patients well? And so that's where we're at. We're on board to ask the questions, and we're waiting expectantly to know how we can move forward with meaningful change for our patients. So that's where we're at.
Hi, my name is Crystal Garcia. I'm the Vice President of Specialty Services, Quality, and Patient Safety at Valleywise Health. And our team consisted of Nelson Silva Craig, who's a Director of Ambulatory Services. One of the bigger players, too, in this that worked with and did a lot of the legwork is Lene Hudson, who is our Director of Care Management, and her team. And the reason we picked our project is due, with our patient population that we serve here in the Valley throughout Maricopa County. We are a safety net facility. So as we were beginning to look at this, we noticed that only approximately 5% of our ambulatory adult patients were being screened for social determinants of health on an annual basis. So we wanted to increase that screening so we can then be able to provide the resources. The other was our screening was fragmented and inconsistent due to some resources, so we wanted to correct that. So our project and the processes that we did was to begin doing a pilot project at a couple of our clinics and also looking at the questions utilized. And as we began the pilot project, the care managers or the care extenders that we utilize began calling patients ahead of time prior to their visits to do the screening and then to be able to determine the resources that can, once they come into their appointment, the resources that they may be able to offer to the patients. And as the pilot went through with this, we saw there was a 70% screening completion that was done for these patients in these clinics. The resources that was then be able to provide, and then the feedback we received from our patients were very positive. And in regards to how they then we were able to explain what this was, the reason we were doing and asking these questions, and then what can be provided to them. So again, being able to hear that positive feedback from our patient's voice was very great to hear. What went well, again, was, as I said, the increase in being able to call the patients ahead of time of their appointment and ask the questions and then be prepared to provide the resources once they came into those appointments. As we've done this, then the plan is we're going to roll this out throughout our inpatient area as well as to all of our other clinics that we do have here in Maricopa County. And a couple of things that to do better or differently. Again, we want to be able to utilize our electronic health record to the full capability that we have. So working through that with the questions that are there, making sure we ask the questions appropriately to the literacy level that the patient population we serve. Also making sure that we have the resources that are available to be able to do this at all of our areas and throughout all of our clinics and our inpatient. It was great to see the collaboration between with the care management. We also did presented the information to our board of directors so they were aware of all the work that was being done through the collaborative and with our care managers and the importance of the impact it's making on our patients. And that's all we had.
Hi there. I'm Sean Phillips, CEO at Canyon Vista Medical Center, located in Sierra Vista, Arizona. I am also a part of LifePoint, like Elias, so I will be making fun of Elias at various points through this presentation. Just calling that out right now. In addition to my responsibilities at Canyon Vista, I'm also professor for administrative pharmacy practice for the Hagerman College of Pharmacy at Ferris State University. I am an instructor of healthcare finance for University of Wyoming School of Pharmacy and also advisor to the dean for U of A's Coit College of Pharmacy. So spend a lot of time being academic. Because of that, I can barely say hello in 5 minutes, so we'll see how the rest of this goes. Elias, I thought we talked about this. You were supposed to defer the remainder of your time to me. We talked about this, but that's okay. I'll still take it anyway. But I am really happy to be here. We had kind of a different type of project than some others did. We really are looking at this from a top level. So in Sierra Vista, Arizona, we're also home to Fort Huachuca, a very large Army installation. We can have 14,000 active duty military, 10,000 civilian workers on post. And many of our workers either come from the military, they have military spouses or military parents. And so that is kind of ingrained in our community. So we often use the Army's tightrope of leadership as kind of a touchstone for our organization. And for those that are not aware of that concept, it is people first, winning matters, and always out front. For us as a hospital, it's always patients first, teamwork matters, and lead from the front. And that's really important for us, and it was really important to use that concept as we built this project. For us, it was around making sure that the C-suite and the board of directors was really engaged in diversity, equity, and inclusion right from the start. So our project was around board assessment, composition, and education around diversity, equity, and inclusion criteria. So I want to call out, we did similar work when I was back in Michigan with Bronson Healthcare Group. So when I started on this project, I, of course, started with ASHA and Stratascan saying, hey, what tools do you have to help us assess our board? And they gave some resources, and they were really, really expensive. I'm just going to be honest with that. And I didn't have a whole lot of money to put towards this project. So I reached out to my friend Alicia Johnson up at Bronson Healthcare Group. And she had a tool right in her toolkit, emailed it to me, and on the bottom of that tool, it says, this can be used for educational purposes, do not, print or recreate outside of educational purposes. So if people need a tool that you could roll out to your board, to your leaders, we do have something. I shared that with ASHA, so you guys can get copies of that for your own use in the future. So we took that and we rolled it out to our 14 board members, and we actually had 13 of 14 respond. I thought that was pretty darn good. And our vice chair of the board, retired colonel, just recently retired as the top civilian on post, said that was the hardest survey he's ever taken. He said that it was really eye-opening, and it really made him think about what he's done around diversity, equity, and inclusion in a different way. And that's, I think, really telling because, at Fort Huachuca, we really pride ourselves on that diversity and inclusion. So Fort Huachuca was the first to use Apache Scouts. We're the first to use Native Americans as a part of the integrated Army force. And we were the home of the Buffalo Soldiers, so for the first black regiments of the Army as well. And we've always carried that forward. So when you go look at my poster and you see those statues that are on that poster, that is the tribute to the Apache Scouts and then the Buffalo Soldier on our poster. So we really thought that we as a community had this kind of figured out, right? The Army's good at fighting, and we're good at now, the modern Army is good at inclusion, and that's inclusion of races and creeds and backgrounds, and now, SOGI data as well. The Army embraces all of that, and we thought we had that pre-figured out in town as well, and we really didn't. So the board took a hard look at itself and saying, are we truly representing this town? Because if we can't have a board that represents the community in which we're serving, how can we really assess and improve healthcare for those different constituencies of this community? So that was the first takeaway off the survey results. We need to do a better job, a more cognizant job of representation on the board. We went out there and we assessed where we were at, and we had good, religious backgrounds, and we had different people representing the LGBTQ plus community. We had good representation of African Americans and Latin Americans and biracial individuals. But as we looked at it, I said, boy, I don't have any Native Americans. And so I talked to a Native American that happens to be our director of our employed medical group, and he said, that's not where you're missing out, buddy. He goes, that we're really not that large of a portion of our community, but you're missing Asians. That is obvious to me. So we kind of took that feedback back to the board, and they said, kind of a light bulb went off, you're absolutely right. And I'm really proud to say that we were able to find a retired colonel, Asian American female, worked at the Pentagon to join our board. She's going to be joining us in July. And that, I think, really kind of helps us look at our board and say, wow, we did a decent job of representing this community. Is it as balanced as we need it? No. But is it moving in the right direction? It really, really is. So I want to thank Joe Clifton for pointing that out, and I want to thank our newest board member, Teresa Walsh, for joining us. The board, of course, that was step number one. Step number 2 is really kind of rolling that down. Always out in front, lead from the front. That means that we need to do that at the C-suite level, the senior leader level, and of course our directors and managers as well. So the next thing the board wanted to do was really tackle what are the HR rules of the road around DEI and how you use that and how you really maximize that out for whatever organization you're serving in. We have not been able to get there quite yet. So we got some of the project done, but obviously not all of it done. And so what was great about this project is we had really strong belief and commitment to this. In other organizations I've been in, there's a certain anti-wokeness mentality out there. People get nervous. I got 1 minute, except I brought his time, remember. Did you add that? Did you? She did. She added Elias's time already. All right, I got 1 minute. So it was really great. We had such strong belief in this and support from the board level, support from LifePoint, our parent corporation, support from ASHA Stratasan to really do this work, and we are making progress. What would we do differently next time? We probably would scale things back a little bit. We bit off quite a bit. It's a lot to chew, but we're making our way through it. One thing that we do have, you'll see that on the poster, is our board is committed to having this as a 2024 strategic initiative. And so this will be built in our organizational strategic plan going forward as well. So at least it won't die after this poster is done and I'm done talking and using up everyone else's time. And I think that's really great. So scale things a little bit differently. Obviously, time was a limitation, and I think that's all I have to say. Thank you.
Good afternoon. I'm Sasha Charlie. I come from Hill River Healthcare, and I'm here representing today our CNO, Susan Kelly, our School Health Services Director, Candy Braby, and Michelle Albrecht-Burke, our case management. We really develop our collaborative around LGBTQ population. Coming from a Native Indigenous background, me and Candy were the Native Indigenous representation on this collaborative group. And we really saw a focus to target this patient population because they're so underrepresented in our data collections. Ultimately, in Native communities, LGBTQ+ is very much still a taboo subject. And so our focus was really around approaching our board of directors, approaching our executive leadership team on how we can begin those conversations to incorporate data collection at our patient registration, at our primary care, PCP, person-to-person first contacts. And in the school health realm, identifying those in our children. Do we see those issues popping up within our student population? Ultimately, our community is really close-knit, close-tight. Our board of directors is appointed by our tribal council. So we have such a dynamic of our board of directors from people who have been sitting on there for 10 plus years to newer members who are appointed within the last year or two. So the dynamic of integration is really different. It's really varied. So that was one of the pushbacks, not necessarily that it's a pushback, but it's just a slow process to get it implemented, to know how far deep in the water do we want to tread? How far can we tread? Originally, we had a big goal to roll out a survey at our community-wide fair, carnival. We call it Muchata, which is a gathering of our people where we have all our traditional events along with newer events like carnival and things, but we still have our traditional dancing and things like that. It's a old meets new way to celebrate. And the question was approached, is this too big of a subject to approach at such a community-wide event? So that's where we had those difficult conversations. So let's start integrating in small pieces. Let's integrate with our directors. Let's integrate with our patient registration people. Ultimately, I was having to talk with Elias here, and his problem is systematic of getting integrated into his EHR. Ours isn't so much systematic, but it's more approaching the conversations with the board of directors to get those permissions to even get it implemented. That was where our struggle was, and we're still ongoing. And we were thankful. We recently had collaborations with our grassroots program called the Hope Group. It stands for Helping Autumns Pursue Equality. And it's strictly based for Otham communities, for Akshan, Pish-Posh, Maricopa, those communities. But ultimately, they have they've been struggling for the past 10 years. I think they've been incorporated since 2012, 2013. So they still feel very much grassroots, that they haven't made any headway, and that starts with the basic conversation of, okay, what do you guys feel when you come to our facility? Do you feel like we're actually asking the questions of what that would serve the patient population that you guys represent? So just initiating those conversations has been a big focus of our project, is to begin those conversations. And because we're such a small community, but we're such a tight-knit community, that how is that going to affect family orientations, family dynamics? Because our patient population is very patient family centered. We pride ourselves on being inclusive to our families. A lot of what we consider is community pride. I was explaining that our onboarding is very intense. We go through a 4-day community immersion program where we go into our community, we go into each individual district, we go into homes, we ask the questions. And so we want to be able to approach those questions with dignity and respect. And that's the base of what we want to approach everything. Okay, are we approaching this specific patient population with dignity and respect? And the truth is, we really didn't know. So that was the focus, is finding those answers. Are we even asking the question? So, and that was our project.
So hello, I'm Kiri Valdez. I'm with Little Colorado Medical Center in Winslow. Our project was compiled by myself, my care coordination quality manager, and our quality CQO, Christy Ross. We, as our department, were looking at some of our biggest disparities. Our department manages the discharge planning. So one of the big things that stuck out to us was transportation. We have a little vortex going on where our hospital is located, where we have the I-40, the Amtrak, and the Greyhound that all run through our community. And it always seems to be that patients who can no longer be on that transportation end up to us. So then it kind of becomes our jobs to get them where they need to go. And unfortunately, with us being a very small nonprofit hospital, we have to be very resourceful in an area with very little to no resources. So we kind of compiled, who are we seeing, who are we transporting, what our costs are, and what our transportation options are. We were able to find data of our transportation all the way back to 2013, but it wasn't until probably 2019 that we started actually tracking FIN numbers, medical record numbers. So we were able to go back and look at those accounts and find out what was their insurance, did they have transportation benefits, where were they going, why were we paying for transportation. So we were able to see a pattern of our biggest place that we send people to is the homeless shelter in Holbrook. So for us, it was, we're sending the majority of our patients to the homeless shelter in Holbrook. What is that costing us? And we were able to find that the majority of the patients we were sending there are out of state, people who were in an accident on I-40, because we are in this area between Holbrook and Flagstaff where there is just so many accidents. So we end up with people in our emergency room that no longer have a vehicle, their family is in another state. So we have to get them somewhere where they can get a rental vehicle or go to where their vehicle is at in the tow yard to get belongings. And so we end up having to pay out of our petty cash to get these people to where they need to go. We found that the majority of the people we are transporting is patients over the age of 65 with Medicare, who obviously does not have a transportation benefit. Our next largest was, out-of-state people who don't have the transportation coverage or were out of network. Our next biggest group was, they have that transportation benefit, but because we're such a rural area, there's no transportation companies that can take those patients. So we were kind of going back and looking through everything, and we found that not only have we been transporting more people, but the costs of transporting people have gone up. We have one transport company who is really good at helping us out getting people to Holbrook, to that homeless shelter, and they recently raised their price from $35 to $50 to get people to Holbrook. There's another transportation company we use that charges us $65 to get someone 30 minutes to Holbrook. Another option for us is sending people to Flagstaff where there's more resources. There's another homeless shelter, and that one costs us $100 to get people there. So for us, it was just looking, as we're the department that does discharge planning, is why are we sending so many people? And for us, it was just, the lack of resources in our area. Another big hit for us was COVID. We have yet to find a transportation company who will take COVID positive patients anywhere we need them to go. The homeless shelter, won't take COVID patients. So then we're having to branch out further, which again is costing us more money in transportation costs. So looking through everything, what went good for us is that we had all of that information tracking for our transportation. And now we know moving forward that we can keep more information on, what do they have the transportation benefits? What are their insurances? Where are they going? Why are we sending them? We also found that, they had that really good coverage for them to get transportation, but no drivers. So then we have someone who should have been able to be taken somewhere with their safe ride option, and now they can't because there's no drivers. So just kind of looking at everything, we're seeing that our costs are going to increase, and it seems as if we've had a lot more people stranded in our area due to the 3 lines of transportation that come through. So for us, it's still kind of ongoing. Some options we had looked at was getting contracts with some of our local safe ride companies, see if they'd be willing to do like a cash pay option for some of our patients who just don't have the insurance. And a lot of them, once we spoke to, wanted exclusivity contracts with us, which doesn't really work when you have multiple people sitting on your medical surge floor, our emergency room, needing transportation, but the company only has 1 driver. We also had a couple of instances where a patient had the coverage, but because we're so rural that they had a driver that was 6 hours away, but the patient needed to go 3 blocks. So for us, it was just a matter of having to not use their insurance and just pay for a local cab to get them somewhere in town, because someone who lived 3 blocks away didn't need to wait 6 hours for a driver. We have looked into using volunteers as transport drivers, but the cost of maintaining a vehicle and just the liability of having a volunteer was just not an option for us. It was also looked into possibly hiring a transport driver, but the cost of maintaining the vehicle and hiring that position was just not something we could do. So for us right now, it's still kind of an ongoing project. We still have a lot to look into to kind of figure out where to go. I mean, can we reach something with a company? Will companies give us a discount? So for us, that's just kind of one of the things we're working on, and it's hard in a small, very rural area where those are so limited. So yeah, that was kind of our project, and it's ongoing.
Great job, everybody. Thanks. All right, so now we're going to do our open forum. You all are catching on. You're going to talk at your tables. What did we hear? What are our reactions? And what are our questions of understanding, and for whom? So you're going to take 10 minutes to create your questions, and then we're going to do the table call out so you can ask your questions. All right, 10 minutes. We're going to start again with table 1 and then table 7. Be ready to go. They forgot to pick a spokesperson. Now they're like, who's going to ask the question?
All of our questions pretty much got answered. It's good to rationalize and understand that everybody's kind of struggling. We're all climbing up the hill on this. Little Colorado, you're not alone. San Carlos is going through the same challenges, and it's a long 90 miles to get to the east side of the valley here. So we're going through that, but we'll defer our time so people can ask the CEO down in Sierra Vista.
All right, table 7 and then table 3.
So ours is kind of a three-phased question. We know that everyone has a barrier and it's slow to make changes in your EHRs and what have you. And we, by the way, we're very impressed with Canyon Vista, with the board work and building that into your strategic plan so that it'll be hardwired and hopefully never go away. But for Havasu, we kind of want to know what EMR you're using and who asks the questions. Is it the registration people? And then does it interface with your EMR, the registration system? So those are kind of our questions.
It will be.
Should be?
It
Okay,
should
there
be.
you go.
There's a
Thanks.
whole team of professionals back there.
Look, I know, right? I shouldn't have doubted it.
You shouldn't have.
So we use MedHost as our system. I'm not sure how many people use MedHost. It has its pros and cons. We did use our registrars to do the questions. So when they're doing that initial assessment, they're the one that is filling that out, that information for us. And the reason it did take so long was it does flow into the EMR, and that was something that we knew going from the front that we wanted to be a part of it, was have that accessibility. Because originally when we were planning, we were just going to do a paper form, and then it was going to get turned in later, and we were going to have to make sure that it got uploaded into the health record on the back end. And so we saw a lot of mess with that. So we took our time, I guess, on the front end of it to make sure that it flowed. So it, like I said, though, it doesn't quite yet show up immediately on the banner when like a nurse or someone goes into their file, but it's in the record. They could pull it up and look at it. So that's still an issue though, right? Because you want it to be easily accessible. You don't want people having to look. And so it didn't fix the whole problem yet, but at least it's there and you can go and dig into it and find it.
Did he answer your question, table 7? All right, table 3 followed by table 6.
Hi, we had a question for Little Colorado, Carrie. You talked a lot about being able to sustain your program and getting the money for the transportation. How are you helping your staff who are dealing with this since 2013? I think you said you had data from.
So it's actually our department and staff that manage the transports. As of right now, our department does have a fund created that we use to pay for these transports. We try to keep a couple $100s on hand. So it's our social workers, our case managers. We are the ones who kind of deal with the more complicated transports, like paying for someone to get somewhere. So thankfully, our facility does have funds set aside for us to use for those. But you know, with costs, and we're seeing more and more frequently we're having to pay for things, we are trying to look into ways to maybe get donations, maybe getting our foundation back up and running to maybe get some funds for that. But as of right now, it's still something we're working on and hoping to find a solution for.
And our question was more focused for the staff morale. So this has been an ongoing problem, and like you said, you have a very small team that deals with it, and you're not changing the location of your city. So we were just wondering if there was anything that you do just emotionally or socially for that team.
So it does get a lot sometimes, knowing that patients need to go somewhere and you know they have no way to get there, and so it does get very frustrating, and it does, oh, we have another transport we need to pay for. And it just kind of, we just have to kind of think of it as, if we don't help get them where they need to go, they have no options. They have nowhere else to go. So it kind of just becomes a, we have to just kind of be optimistic about it and think about, you know, if we don't help them, nobody else will. And thankfully our hospital is on board with that as well. It's, if we don't do it, there's just no other options. And so that's kind of just how we have to get through it. And thankfully, our social worker is amazing, and she helps us out sometimes when things are a little rough.
Is that good, table 3? All right. Table 6, followed by table 2.
We don't have a spokesperson over here either. So I will go back to Elias. I mean, we will piggyback off of her conversation, but the vetting process for your questions, we just wanted to know what that process looked like. So did you have listening sessions? Did you bring the community in? How did you vet that process?
So we actually, at the time when we were doing the questions, we didn't have our PFAC up and running, so we would have liked to go through our Patient Family Advisory Council. We got a small group from our safety champions, which is frontline staff and people that have lived in the community, and then we ran it through our governing board. And that's kind of how we went about it, which is all community members, obviously. But yeah, I think we wish we would have had our PFAC up and running at the time, which was like back in February. But we were kind of late to the game, and COVID really threw that off, so we had to revamp it.
To answer your question, table 6, table 2, and then table 4. Where's 2? 2. Oh, there you are.
Two by myself over
You're 2.
here.
Okay,
They
table
all left
2,
me.
what is your question?
So my question is for Crystal. I'm sure you've all heard that the social determinants of health is something that's going to be required by CMS in the future. Is that what EMR do you use? And then how did you integrate collecting that data? Is it from case managers? Is it something physicians are documenting that you can code off of what the physicians are documenting? And how did you push out the education for your staff on gathering that data?
Thank you. So currently, our case managers are the ones that are collecting. Let me start. We use Epic as our EHR, and so we are using the social determinants of health module that there is in Epic. There's still, potential to even use it more, but that's what we're beginning to utilize. Our case managers, we have case extenders that we utilize to help collect the data, and then within our EHR is being able to utilize the Z codes and to then those go through the coding process and using those more to the potential. That was one thing we noticed, that we were not using or documenting for the Z codes to be able to bill for those services. And so that's, again, the process we're working through as well to make sure we capture all that can be utilized. And we're doing that from an inpatient and an outpatient perspective. The training that's went out, again, we have, it is also part of our strategic plan that we're moving forward with. And so having the care managers educate the importance of doing the social determinants of health it goes out to all of our employees. Again, there's probably more that can be done that we're working through, but that is the initial process, is again using our care managers and those care extenders to be able to do this.
Does that answer your question, table 2? Check with your friends. Table 4, followed by table 8.
So this question is for anybody who feels comfortable answering the question on the panel. So at Valleywise Health, we follow a Lean Six Sigma model. So using Lean Six Sigma terminology, all of you are doing fantastic work. What type of formalized control plan do you have in place, or are you thinking about putting a control plan in place to ensure that your good work continues?
Who wants it? Okay, stop talking all at once.
All right, so I'll take a stab at it, even though I'm not exactly a Six Sigma person. I'm more of a lean process person. So everything is run charted in my life, as Elias remembers. So run charts can explain everything. For us, we've already started collecting the baseline HR information. So we have that demographic. That will kind of create the current what is actually happening. And what we want to do is kind of track if our diversity amongst the leadership changes over time. And it's going to take us quite a bit of time to develop that and see if our education and everything is working out. So we don't necessarily have the patient-specific metrics built in yet. We're on Cerner, but our version of Cerner is actually controlled by UHS, which makes it a little bit difficult, being a LifePoint facility, trying to tell UHS what to do. So we aren't able to build a lot of those good reports and get good data out from that aspect to see the patient care aspects, but at least we're going to be kind of building the run charts to track the HR aspects of diversity, equity, and inclusion.
Does that answer your question? Yes. Table 4. All right, table 8, followed by table 5.
Hello, you guys can hear me. Okay, so we just have a question about data collection. Have you had any pushback from any of your patients to answer these questions? Because we think that that might be a huge barrier.
Who's your question for?
I guess Elias.
Popular.
Data.
Well, you had quite the story.
Oh, I guess, yeah, no. In all honesty, it's still relatively new. I haven't gotten to my level a lot of conversations about pushback. That doesn't mean that it's not necessarily happening. And I haven't really done a really great job yet on going and having those follow-up questions about how everything's going yet. So that's probably something I definitely need to do, is spend some time with our registrars and our admitting team and see some of the barriers that they're facing. But I haven't had anything escalated to me yet on that. I'm sure because of conversations I've had with other people in the room, though, there is definitely some pushback from community members on filling that out. I direct you to some of them after that to have that conversation, because I think that they were facing that on, why are we being asked this? We don't want to fill this out. And then that kind of clogs up your system. So you don't want to have people delayed in registering and then pushing back everything else. So, but from us, no, not yet. I'm sure we will, though.
Thank you.
Excellent. Table 5, followed by table 1 again.
Hi, y'all. Ooh, hi. I don't want to pick on you, Elias. So anyone is welcome to answer this if you'd like. But it sounds like, especially with the project that you all are undertaking, that there is a willingness and a comfort from your frontline staff to share where they're seeing issues or where they're seeing places of improvement. And my question is kind of more general than the topic itself, the project itself, but what do you think is either unique to your organization or could be done within other organizations to foster an environment where frontline staff feel comfortable saying, we don't know how to handle this, or I see this issue, how do we fix it? So it's not as much a project itself, but there's an environment that created the space for that project to exist, and I'm more interested in that.
There we go. It goes down to culture that you create for your facilities. And we're not perfect. We have a lot of problems, obviously. But we really put an emphasis on allowing revenues for our staff to communicate with not only leaders like myself in quality or anyone on my team, but the administrators as well. So we do things, and it's not unique to our hospital, but we call them sick cards or learning boards. And so that's one venue that people can post issues on that they're finding. We have a risk management system in our SIMS that people can speak up on. We really focus on our frontline participation in different committees. So like one of the things I like to highlight is our safety champions, which is we have a representative from every single unit, so not just our clinical units, but all units. And they can bring ideas, and that's, myself participates in that, and typically we'll have at least 2 other administrators there, so like our CNO and CEO or COO, one of them there as well. And it's a lot of good discussions on issues that they're seeing that we just can't see. And then it's the constant kind of rounding and stuff like that. So it's being accessible to our staff, making sure that our leaders are doing the rounds on the floors and making sure that our executives are doing the rounds on the floors. And we're getting better at it. We go through ebbs and flow, right? Because you have budget seasons and things that come up and you can't get out of meetings sometimes. But it's really making that focus. And I think that that's one thing that we do a really good job at is making sure that we're available. And then the other thing that, sometimes we do better than others is coming through. And so The worst thing you can do is if you constantly keep getting asked things for change and then you never are able to act on those or never able to impact those, they're going to stop coming to you because they just don't see any benefit in it. So it's when they do ask things like this or identify problems like this, it's how we solve them and then communicate with them. Hey, we're still working on it. It might take longer than you expect. Or at least giving them that feedback that we weren't able to accomplish this, because that's better than nothing. So I think that's something that we really, really try to do, and then that kind of works on the culture that we have there.
Great. Table 1, back to table 1. Do you have another question?
Hi, yeah, question for anybody. How are you using telehealth to reach patients? And if you're using telehealth, is it accessible to people with disabilities like my community, the deaf and hard of hearing?
Ooh, tough one. Who wants to take that?
We do use telehealth at La Paz because we're sort of out in the middle of nowhere. I don't know that we've done a very good job of seeking out the deaf and the hard of hearing to know if we're doing a good job, but I know that we use telehealth. We use it for cardiovascular services that are outsourced, for mental health services that are outsourced. I think there's a couple other service lines. So that definitely sparked some ideas in my brain of following up to see if we're actually being effective for special needs. So.
Anybody else want to take that one? All right, table 7, do you all have another question? And then table 3.
So this is for Sasha at Gila River Healthcare, and we were, well, kind of, April and I were wondering, we didn't even ask you, but how your board is handling the, working with the transgender or sexual orientation issues. Are they, how, so that you can move forward and work with that population, how are they handling this?
Well, it's been a very slow process. So one thing that we've tried to implement, or we actually are implementing, is safe zone training. We're getting to the root of what their first interactions were as a person with the LGBTQ plus community, and learning how they interact with them, how on a personal level, what their triggers are on where they first had their first interaction, and then giving them that aspect, okay, how would they feel if we called it, like, I can't remember the term exactly, but straight person privilege. If they were only given so much money to buy a straight person privilege, how would that react to them as a straight person versus an LGBTQ plus? For example, one of the setbacks was, what if you could not hold your person's hand in front of your family? What if you could not send your children to school without having them retaliated against because their mother or father is gay or transgender or whatnot? So it's those triggers, those personal triggers, getting them to look at themselves on a personal level and think, okay, this is something that's always been discussed and it's always been around, but it's just that the openness of the discussion has been limited. So we're starting small with those small groups of patient registration, primary care, and then we went to our executive level team, and then going to our board of directors. So it's been a slow process, and I will say that it's we can't well measure it yet, but I think with the outcome of this, we might have a good answer for you, let's say in the fall.
That's great, thanks. Table 3. Any more questions from table 3?
So don't take this the wrong way. I'm a big believer in addressing the social determinants of health, and this is a question for everybody. But our healthcare system has traditionally been sort of a dumping ground for societal ills. Like, okay, well, we'll just fix it in the healthcare system somewhere. And when we talk about, transportation insecurity, if we were trying to fix a problem at our organization, we might do a root cause analysis, or we might ask the 5 whys, and we would get to the root cause. We can't really do that with social determinants of health because they come to us with those because they're more of a societal issue. So do you have any strategies or ideas of how do you make these programs sustainable without burning out your staff on things that aren't really what they're trained to do, like your providers?
What a great question.
All right, so it always seems like these.
If nobody wants it,
yeah.
Sean has to take it.
Is that the game we're playing now,
Yes,
Leanne?
that's
Thank
the
you for that.
rules.
That's wonderful. Oh, saved by the right. So I think you bring up a good point. I mean, obviously, we're hospitals. We don't have unlimited funds. We don't have all the resources we need to even maintain our core operations and replace the capital that we have that's aging and breaking down and everything else, let alone meet the stresses of recent inflation on wages and supplies. But it doesn't mean that we shouldn't be advocating for those items that create the social determinants of health. Our mission statement at LifePoint is making communities healthier, and I always say that's beyond the four walls of the hospital. So, we make sure that we have executives on economic development, that we have them at Boys and Girls Clubs, that we have them at Chambers of Commerce, that we have a strong advocacy voice through ASHA, but through other venues too, myself in military affairs, to make sure that we're addressing those key items. So, what does it take to create a stronger community? I believe that takes transportation systems to get people and goods in and out of your town. It takes a good education system to teach people to how to have economic hand up through the educational systems, whether that's universities, community colleges, high schools, trade schools, everything else. And that needs to be healthcare. Healthcare is a core infrastructure element in every community. And when we position ourselves like that, we can have a stronger voice to help those other social determinants of health, those transportation systems, those neighborhoods, those employers, those colleges and educational systems to help create better communities overall.
Does that answer your question? That was a very hard question. How do you solve poverty?
Right, solve poverty.
How do we just solve poverty and it's all fixed? All right, give our panelists a round of applause.